Well, good morning, everyone. I am Dr. Sue Visser, and I'm Deputy Director for Policy and Extramural Program from the Division of Vector-Borne Diseases at CDC. And on behalf of myself and all the leadership of the Division of Vector-Borne Diseases, just wanted to thank you so much for being here in person. Welcome to everyone who's in our Zoom rooms online. Those Zoom rooms are interactive rooms, just like the tables that you are at. We're really happy to engage those who couldn't travel with us today, but who are nevertheless going to share their feedback with us, and we're so grateful. Also, welcome to those of you who are live streaming the event across the nation. They'll be able to participate and watch the opening session for the next hour, as well as our closing session, where we'll brief out on what we've done together today. So thank you to everyone. I want to, before we get started, thank MITRE and Code, who really helped us put this meeting together. I've been saying it sort of feels like a wedding reception for the Vector-Borne Disease National Strategy, because we have invited all of you because you've been part of this strategy, the development of it. You participated in 2 requests for information that went out to the public. We've had many, many conversations with all of you, and so you're really important to both this and then the implementation of the strategy. So I'm so glad that you are participating with us. And MITRE and Code, especially Liz Roberts from MITRE and Miranda Chan as well from MITRE, really played a huge role in all the details of the event, and also Paul Kuhn and Joel Gurin from Code, who they do really exceptional different meetings, which I hope you will find this is not your standard federal meeting. I hope it's a lot more interactive and fun, and I'm really grateful to them for helping us cross off all the little to-dos to make this meeting happen. So thanks to them. Today is about you. As I mentioned, the federal strategy was developed by federal members from a large number of federal agencies, but we recognize that developing a strategy has to include feedback from the public that it is intended to serve. And so we're shifting our focus from the federal members coming together and creating something, which is now in print on the table for you. And we'll be going through the content of that a little bit later. But we want to share who you are. So let me see if I can click things. There we go. And next slide, please. So we endeavored to have a really diverse group, both at this meeting, but also at each table. So you will find that there are not tons of one affiliated type of person at each table or in the Zoom rooms. We had over 50 responses to our participant engagement tool that we sent out ahead of time. And here's a quick little view of those participants and how they lay out. You can see we have a really nice distribution of federal members, are the green ones that are not on there, but 13% federal members, 28% patients, patient advocates, patient-driven research organizations, 32% public health or professional organizations, and 26% research and academic organizations. So we're really excited to have this diversity, and we think it's really going to feed into great conversations today. I would like to also go through just a couple of housekeeping items. If you could go to the next slide for me. Great. So bathrooms are located both behind the stage in this direction and also near the elevators in that direction. The HHS cafeteria is on the 8th floor. You'll need a federal person to take you up there, but there are many of us here. So please see me or anyone at that back table if you need to go upstairs. Please vote in the interactive activity that is open until noon with free Wi-Fi available here on the ground floor. You shouldn't have any problems, but let me know if you do. Already mentioned you need an escort to leave this great hall on this floor, and we're really grateful for all the virtual folks who I know it's probably less engaging than being here with us in the room, but we're really happy to have you. So with that, I would like to introduce Dr. Leith States, who is our Acting Deputy Assistant Secretary for the Office of Science and Medicine. We're really grateful to have all of their support, and I can tell you that it has been a really unique experience to be supported in the way that we have by the Assistant Secretary for Health and the Office of Science and Medicine in particular. You can only imagine that in public health, where we have all the competing priorities, all the natural disasters, the pandemic, emerging threats constantly, to have the constant recognition and assistance from the Office of the Assistant Secretary for Health. It has been truly remarkable. So I would like to welcome to the stage Dr. Leith States with my gratitude.
Wow, those are kind words. Good morning, everybody. So bear with me, I'm going to get situated here so I'm nice and comfy here for you. So, Sue, thank you so much for those kind words. I always get geeked up seeing the Vector-Borne disease team here from CDC. I always know something good is going to happen when they're on site. So you see Lyle, you see Sue. I know Ben's not with us today, but hello, Ben Beard, wherever you are in this wonderful world. And a good morning to all of you here, everyone on Zoom, everyone in the live cast. It's truly an honor to be able to welcome you to this public venue, this public engagement, this roundtable on the Vector-Borne Disease National Strategy. As Sue mentioned, my name's Leith. I've been honored to be in OASH for the last 7 years or so. I'm the Chief Medical Officer to our Assistant Secretary, Admiral Rachel Levine, and as Sue said, I'm fortunate to be serving as the Acting Director for our Office of Science and Medicine, which is where I've had the opportunity to work with folks like Dr. Honey and tangentially Jim Berger in the back there as we pivoted not just towards tick-borne disease, but now expanding the aperture towards vector-borne disease. So it's really reflective of my good fortune to be tied to so many what I would call heavyweights across HHS and to be tied with you all in terms of trying to elevate the prominence, the primacy, and the need to act and create solutions. And that's why we're here today. I was going to tell you a little bit about OASH. Maybe I'll do that just to hit the wickets of what's on my paper here. So OASH, for folks that don't know, that is our shorthand for the Office of the Assistant Secretary for Health. We oversee the department's key public health programs and strategies, a number of presidential and secretarial advisory committees, the 10 regional health offices, and the U.S. Public Health Service Commission Corps, and the Office of the Surgeon General. Like I told you, I came to OASH 7 years ago, and that was after a 10-year career as a Navy Medical Corps officer. And over the course of that career, I was very fortunate to work with corpsmen, with environmental health officers, with entomologists, with a variety of other staff corps with the interest of keeping our force healthy, keeping them healthy, protected, well, thriving from vector-borne threats. So a fair bit of my job was built around how do we keep folks from succumbing to the worst of what's out there. And the majority of my career was spent with the Marines, so if you will indulge me, I'm going to do a quick Marine Corps story. It won't be off color, I don't think, I hope. We'll see. So, but I hope it characterizes what I'm trying to convey here with you all today. So, Marines, in theory, would follow orders from medical. But that, for a group of 18 to 35-year-old invulnerable people in an infantry battalion, does not go over well, and frequently you have folks paying lip service to whatever it is you're telling them to do. So, case in point, doxycycline as chemoprophylaxis for malaria. Folks will not take it, but if you also tell those Marines that, hey, it's a good prevention and treatment for syphilis, chlamydia, and gonorrhea, wouldn't you know it, it skyrockets their compliance rates through the roof. And while unorthodox, it's an adaptive response to your population, to your community, to find a realistic solution that's going to be used, that's going to have the desired outcome, right? So this gets away from just having a guideline, having a strategy, having a plan, having a clinical algorithm, and having it go nowhere because it loses connection with the folks at the deck plate, at the end user level, which, for my purpose in looking at you all today, not saying that you represent the Marines, but the picture here is you have the best capture on what it is to take the strategy to make it realistic and applied and have the impact desired. So with that, I want to say I am very, very appreciative of your time, your presence, whether online or here in person, and I hope that we're good stewards with that effort and time today. So I'm going to pivot quickly to what our end has been as federal partners. So to address the rising public health threat of vector-borne disease, Office of Science and Medicine and the CDC's Division of Vector-Borne Disease led an interagency strategy or interagency process to develop the National Public Health Strategy to prevent and control vector-borne disease in people. As many of you know, that plan was released in February 2024, and it was developed in response to the K-Hagen-Tick Act of 2019. The arc of that was a bit ambitious to coordinate 17 federal agencies across 5 priority lines of effort, and to do it in a way that would create a good intersection not just with Congress but also with the public. So in that spirit, we submitted the plan to Congress, and we have made it available to the public. And if you're truly interested, you can look up this publication. And now, while my notes say you can look on OASH website and the CDC website, in the last couple of days, the CDC website has undergone vast changes. So if you encounter broken links, it's a really cool-looking website. It just may not be functional at the moment, but give it the college try and see what happens. Now, as for OASH, we've continued to prioritize vector-borne disease prevention, and that's been demonstrated in one of our recent reports. Now, this is a long title, so give me a moment here. I need to read it. Lyme Innovation Initiative and LymeX Innovation Accelerator, multi-year plan to change the Lyme disease status quo. That's a lot of words, but the distillation here is it's a multi-year plan highlighting the past, highlighting the future innovations that our office will continue to pursue addressing Lyme and other tick-borne illnesses. Like any effort at coordination, success is really only going to be realized if trust, transparency, and meaningful collaboration continue across all interested parties, inside and outside of government. So we are really delighted to host all of you today to hear your perspectives as patients, as advocates, as researchers, policymakers, and public health professionals. And I just want to leave you with a small charge for the day. I don't know where I got this quote from. I don't know where to attribute it, but it's been coming up for me recently. Today is the day I do better. So today is the opportunity to bring your best self to this cause, to be honest and exhaustive, to drive towards tension in the interest of finding realistic solutions. Do not be resigned to sit back and receive, but take advantage of the opportunity to bring your truth and perspective to bear. The national plan was a labor of love, but it only makes an impact if it moves from strategy to operational and tactical and deck plate impact for the community and populations that you all largely represent. So again, I thank you for your time and attention. It's been a pleasure, my honor, to be up here with you this morning. And I want to extend a special thanks to Dr. Visser, to Dr. Peterson, to the entire CDC team that has been partners in this, and I really hope that we have an impactful day. Thanks again.
All right, and while Dr. Lowell Peterson comes up to the stage for historical reflection on how far we've come together, just wanted to recognize Kate Wolf, who's our Chief of Staff at CDC, came in. She has been a really strong advocate for vector-borne diseases, has been locked armed with us most recently in the dengue response, which we are leading a program-led response right now to protect the people of Puerto Rico from an emerging dengue threat. So thank you so much for being here and for participating in this event. And with that, I'd like to hand the podium over to Dr. Lyle Peterson, our division director, my boss and creative leader. Thank you so much.
So thank you, Sue. So I just want to start with a brief story and an episode that happened a couple weeks ago. And that was when an AP reporter who's quite experienced and knows a lot about our diseases came to our division to learn more about vector-borne disease and what we were up to. And so he interviewed Dr. Visser for about an hour and a half. And she gave her whole perspective on what was going on with vector-borne disease. And so he put out his first story a couple days ago. And he took one quote from Sue. And that quote was, "It's very bad, and it's only been getting worse." And I think that really, actually, he's an experienced reporter, and I think it really did sum things up nicely. And I think most of you would probably agree with that statement. It is bad, and it is getting worse. So I think the picture is bleak, really, because all of these vector-borne diseases are increasing. And I really, frankly, don't see an opportunity to turn anything around dramatically anytime soon. So despite this, I think we're actually at a turning point. And you're part of that turning point, so I'm glad you're all here. But why I think we're at a turning point, given this kind of bleak picture, is what I'd like to kind of discuss right now in the next few minutes. And I've been at this business 35 years, off and on, working on vector-borne disease. And so I'd like to kind of start with my first job at CDC, which was about 35 years ago, and I was an Epidemic Intelligence Service officer. And as part of that, it's a 2-year applied training program. And as part of that, you have to do a surveillance project. So I really wanted to do my EIS training in Hawaii, but I got assigned to Connecticut. And that actually changed my career. And so when I started doing this survey, looked around to see, well, what can I do? I discovered that the state of Connecticut laboratory had started doing Lyme disease testing. And so as part of this testing, they required submitting physicians to turn in a case report form. So I was walking around the office, and then there was this whole pile of these case report forms, and I said, well, what's that? And they said, oh, it's Lyme disease case report forms. Well, nobody thought it was very interesting to look at Lyme disease. It was kind of more of a medical curiosity at the time, rather than a true giant public health problem. So I coerced one of our assistants to enter all this data in a computer, and I looked at the data, and I discovered, much to my surprise, that there were 1,149 cases of Lyme disease diagnosed in Connecticut over the past 2 years. And I thought, wow, this is an incredible number, and I still remember that number to this day. But to put things in perspective, 1,149 cases is about what we in the country have for diagnosed Lyme disease in a 5-hour period during Lyme disease season. I mean, 2 years versus 5 hours. So you can really see how things have changed. Well, anyway, I finished my EIS training, but couldn't stay in vector-borne disease simply because there were no jobs. Nobody really cared about vector-borne disease. So I ended up working on HIV/AIDS for about 10 years. And then from there, I went off and worked in Germany, helping to start the German CDC. And as part of my time there, I worked on Lyme disease also. And discovered there, like here, Lyme disease was increasing. So that was all fine and good. I loved living in Berlin. But then in 1999, West Nile happened, surprising everyone. And until then, the mosquito-borne, vector-borne diseases weren't very prominent in the U.S. There were less than about 100 cases per year. And it was regarded as kind of a dying field. And in fact, leading up to that, Yale University closed down its renowned arbovirus program 1 year before West Nile came. It was really bad timing. But West Nile really did change everything. Suddenly, we went from 100 cases a year of mosquito-borne disease to, a disease that was causing thousands of cases every year. Birds were dropping from the sky. It was kind of viewed as really scary. We found out it contaminated the blood supply. It was transmitted by organ transplantation, and it all looked pretty amazing. And it really did change things. And so what happened is in 2000, I still remember this to the day, is that NPR interviewed me. And I remember it because my kids were screaming in the background, this interview. And so at the end of the interview, I said, God, you know, I live in Colorado because that's where our division is based. And I thought, God, I wonder when, I told the reporter, I wonder when I'm going to see dead birds in my yard. You know, and New York seems so far away. And lo and behold, 3 years later, I did see dead birds in my yard, but I also got West Nile myself. And I can tell you it was the sickest I've ever been in my life. It's the last time I ever called West Nile fever a mild disease. And what was really kind of disconcerting about this was that it took me about 6 months to recover. I had this profound fatigue following West Nile, which brought a lot of realization that following many of these vector-borne diseases like Lyme, there's this prolonged fatigue syndrome, which is just horrible, I can tell you from personal experience. I was a marathon runner at the time, and I could barely walk up the stairs of my house. So the good part about all this was Congress did appropriate money for West Nile virus. It was the first time that Congress appropriated quite a lot of money for a vector-borne disease. And we did a lot with that money. We started the ARPANET surveillance system, which still exists to this day. We funded state health departments for prevention and control. We created national prevention and control guidelines for West Nile, and we funded university-based centers of excellence. So that was all good. But after several years of several spectacular outbreaks, the public kind of moved on. You know, West Nile didn't seem so exotic anymore. People were thinking about other things. And at the same time, tick-borne diseases were increasing, but it really didn't get a lot of traction either. And that was because, you know, spectacular viral mosquito-borne outbreaks make headlines in the newspaper. But with Lyme disease, which was happening every year, and people kind of expected it to happen, it never made a headline in the newspaper. And thus, it didn't get a lot of political attraction. So, but it was becoming, all these tick-borne diseases, particularly Lyme disease, were becoming a formidable health problem. Despite all this, in 2009, the OMB examiner of our budget came to the conclusion that vector-borne diseases are no longer a problem, and much to my horror, zeroed out our entire vector-borne disease budget. That was a little disconcerting, to say the least. But what happened was, fortunately or unfortunately, depending on your perspective, is there was a giant outbreak of West Nile virus in the Midwest that year, which essentially saved the entire vector-borne disease budget. And the OMB examiner after that became a convert. But that really didn't change things either. It didn't really increase the budget, it just stopped it from getting eliminated. And then chikungunya virus came to the Western Hemisphere in 2015, which infected about 20% of the Puerto Rico population. And this is, many of you probably haven't heard about chikungunya virus. It has nothing to do with chickens, but it causes a crippling arthritis, and it's really a horrible illness. And, but it only really affected Puerto Rico, and so it didn't get a lot of traction either. And then Zika virus after that came a year later. That didn't get a lot of traction either until we discovered it caused birth defects. The first mosquito-borne virus that we discovered that causes birth defects in humans. So that garnered the public's attention. And so Congress gave us a very large bolus of money, but it was only temporary. In fact, in that year, to combat the Zika virus epidemic, we got about 10 times the budget of any previous year, all in 1 year. So, but with that money, we put it, I think, to really good use. We funded university-based centers of excellence again. We funded increased capacity for health departments, which had been eroding over the past number of years because of the budget cuts. We increased laboratory capacity, and we were able to conduct downstream research that was able to make a difference in public health over the next couple of years. But my big real concern was, are we going to repeat the West Nile experience? Are we going to get a whole bunch of resources, build capacity, and then suddenly the interest wanes and everything falls apart again? So my other concern was that diseases like Lyme disease weren't getting a lot of traction either at the time, even though they were becoming really formidable public health problems. And so to really try and prevent this boom and bust kind of cycle, we needed a real call to action to really bring the public's attention to this growing public health threat. And we also needed more public attention, and we needed political awareness to this problem of both mosquito-borne and tick-borne diseases. We also needed an expanded network of collaborators. These are very complicated diseases, involve a lot of different people, and it was really obvious that we couldn't really handle, no single institution could deal with this alone. It really required a collective effort of everyone. So we published an editorial in the American Society of Tropical Medicine and Hygiene Journal, which is a pretty prominent journal in our field. And we're calling for a national strategy. We wanted to get everybody working together. We also created what's called a vital signs article, which is a pretty prominent publication in the CDC realm. It's one that the agency really gets behind. And in this article, we took, instead of doing the traditional thing, talk about Poisson virus or Lyme disease or whatever, we put them all together and said, this is the big problem that we're having with all of these vector-borne diseases. And that actually got traction, particularly since we said, well, there's more than 1 million of these cases that have been reported in the last decade. They're doubling. We've got more vector-borne diseases being discovered and coming into our nation, and both tick-borne and mosquito-borne and flea-borne as well. So after that, 2 important things happened. The first was the formation of a tick-borne disease federal advisory committee, and that ran over a 5-year period, sunsetting in December 2023. And I'll totally admit that we were horrified by the fact that we're going to have this tick-borne disease advisory committee, because it's a lot of work. And there was a lot of controversy between Lyme disease treatment and diagnosis and everything, and everybody pitted against everybody else, and we thought, oh my God, this is going to be something potentially really horrible. But it actually turned out to be great, and it turned out to be great for a couple of reasons. One was it highlighted the need for decisive action to combat tick-borne diseases. The other thing is it created recommendations, practical recommendations, to address tick-borne diseases, and many of those recommendations are incorporated into the national strategy today. The other thing I think that happened that was really quite productive was that I think it really solidified the relationship between advocacy groups and the federal government. And I think many of our partners are here, patient advocates are here today, and I'm very proud that we now have a much better relationship. we don't agree on everything, but I think we all agree that we all need to move forward. The second was the creation of the National Framework for the Prevention and Control of Vector-Borne Disease, which is the subject today. The framework which we originally published in 2020. And the framework involved 5 goals, and it was created by 5 federal agencies and EPA working together. And it detailed the first national vision, mission, and strategic priorities for the federal government. And it outlined 5 strategic goals that really are the formation of the backbone of the national strategy that we're talking about today. And one thing I think that was really important was actually Goal 5. And Goal 5, to summarize, it's really simply put, to create the means to respond to vector-borne disease threats. And what we learned from the Zika experience was that you can make all the recommendations you want, and you can create the great science to deal with things, but if you don't have the means to implement them, nothing's going to happen. And as a result, I think, of Goal 5, our division budget since Zika has actually tripled. And most of that increase has gone to creating capacities across the country. We don't spend the money internally. We want to build our partnerships with everybody so that we can respond to the threats that we have and also respond to any new thing that happens. And that really involves building capacity across the whole country. So that brings me to the current day. And as was mentioned, the Vector-Borne Disease National Public Health Strategy was authorized by the K-Hagen-Tick Act in 2019. And I have to say, they gave us 5 years to do it, and we actually did it with about 3 days to spare. And it was completed at the end of last year and promulgated in January and February of this year. And so we're focusing on the 5 goals of that national strategy today. So kind of looking back over my career, at least with respect to vector-borne diseases, I think Dr. Visser's quote was accurate. Everything has changed for the worse, and it's not getting better. And I've seen Lyme disease go, as I mentioned, from 1,000 cases in Connecticut over 2 years to we have now almost 500,000 cases every year, we estimate. These are people just being diagnosed. West Nile virus, chikungunya, and Zika virus have emerged in the Western Hemisphere. Worst of all, I got West Nile, but I did recover, thankfully, but it took a long time. Dengue fever, dengue has increased about 20-fold since the turn of the century, and we have a big epidemic going in Puerto Rico right now. We also have hundreds of thousands of cases now of life-threatening meat allergy from tick bite. I mean, who would have imagined that tick bite can make you allergic to eating meat? And so this was a condition unheard of until recently. So given this kind of bleak kind of picture, why do I think we're at a turning point? For a couple of reasons. One is I think we have increased capacity and momentum to make significant progress. The second is we have a strong and growing network of collaborators all working together to address these problems. We must draw on the universe of everyone's skill to really combat these problems, to make headway. And many of our collaborators are participating in this meeting and here in the room and both online. We also have political support and momentum. At least for now, we have a steady funding stream, and there will be no easy victories, and we must be in this for the long run. It's going to take a long-term effort. We also, I don't think we're going to, the victories that we make aren't going to happen tomorrow, and they're not going to happen easily. So I think that steady effort of all of us working in this room and online our collaborators, is very critical to make a big difference. So the other piece of this is I think technology is helping. We have new technologies that can be applied to vaccines, vector control, diagnostics, just to name a few. And finally, we have a national strategy for the federal government to guide us forward, which is the subject of why we're here today. So we need to prioritize among the many recommendations in that national strategy and action plans in that national strategy, because you can't do it all at once. And that's why it's important for all of you here, both in the room and online, to help us prioritize so we can meet your needs. So with this, I look forward to your input, and I look forward to a great discussion today, and because I think your input is critical to us, and I really appreciate the time you've spent or spending with us today. So thank you very much.
Thank you so much, Dr. Peterson. You know, the irony of that quote is that I think I have personal relationships with about 90% of the people in this room, and I think you all know I'm like an eternal optimist. So it was like the most ironic thing to have that be the quote that is taken. But nevertheless, we're moving into now a period of great hope. We have achieved so much together. Everything that Lyle said, 100% true. We do think that there is a turning point. That is my phone asking me to check into Southwest. So Holly, if you could please turn that off, that'd be great. With your help working together, we have more than doubled the budget that CDC has to dedicate specifically to vector-borne diseases. That has resulted in more than doubling the budget that goes out to the now 65 jurisdictions that have vector-borne disease programs, the states, the big cities, the U.S. territories. We have established centers of excellence for vector-borne diseases. We have established training and evaluation centers that together cover 9 regions of the U.S. We have increased our support to our national partner organizations, many of whom are here today, to help us with lab and with local public health and state public health, and to support all of those really critical arms of the public health machine, and to do more because we have so much to do. So my job, before asking you really to help us prioritize the 19 strategic priorities that we have in front of us, is to make sure that you are super familiar with that beautiful bound copy of the national strategy sitting on the tables. We also have them, obviously, the PDF available online. I'm going to take you through really quickly the national strategy to orient you towards the 5 goals and to give you a little bit of background. So next slide, please. This is the QR code for the electronic copy. As you heard from Leith, we had a massive, we did a complete spring cleaning of our website at CDC to help you find information faster, more successful messages, public health messages to the public, to clinicians. With that means that most of our redirects are either coming online, being updated, or Google hasn't learned them yet. But stick with us over the next couple weeks. The algorithms will catch up, and you'll be able to find everything. This QR code should take you on your cell phones to a redirect, and Holly's dropping into the chat for our Zoom participants the direct link to that PDF. Next slide. As mentioned, we had a large number of departments, 17 total federal agencies that collaborated with us on developing the national strategy, many of whom are online and with us in the room today, and I'm so grateful for that partnership. When we first started this process, we did not know that there was any single way of pulling all of the federal members together on vector-borne diseases, and now we are a tight community, and we know each other, and we can reach out to each other. When we needed a connection to DOD for dengue, we knew exactly who to go to. Those sorts of things, really, you can't replace relationships. And so we're really grateful for all of these federal members. Next slide. And a special thanks to Drs. Honey and Desautel, who are in the audience today. Again, could not do this without having a strong amount of leadership and dedication and time and effort from our parent department. and the Office of Assistant Secretary for Health has always been there for us. Also, Deanna LaBelle, who all of you know that young, bright talent is critical to making everything happen, and she's a fellow that works closely with Daniel and Kristen, so thank you to her. Next slide. And the background is pretty simple. We developed a framework first in response to that call to action that Lyle described to make sure that we had the vision, the mission, and those goals and strategic priorities set up as the skeleton for a full national strategy. And we released that first to show Congress and the public and all of you that we were thoughtfully convening the federal government and trying to build something that we could implement together in a coordinated fashion. So that was developed first. We onboarded a couple more federal entities and then built out the full national strategy in response to the Kahagan-Tick Act. And Senator Susan Collins has been a huge tick-borne disease advocate, but she's really an advocate for vector-borne diseases as a whole. From the great state of Maine, they have a horrific burden of tick-borne diseases. It is just a super bright spot in terms of incidence on the map. And we are really grateful for her ongoing support, which has led to those budget increases that I described earlier. The Kahagan-Tick Act has really spurred congressional attention and support in many, many ways for this work. So we submitted to Congress, next slide, and this is what we call the placemat. If you go, there we go. And it's just a quick little snapshot of the 5 goals. We have 19 strategic priorities. We have 42 objectives and over 120 sub-objectives. So this is a massive strategy. Holly and I know it almost by heart. So if you need to find something and you can't find a priority that you're concerned about, please let us know. The one really important piece that is not included in the strategy is actual service provision. And we know that treatment is absolutely critical, and providing those services to the public is critical. It's just not within the domain and the scope of the federal agencies that participated in this strategy. It's nevertheless important, and our colleagues at HRSA and CMS and some of the agencies that participate do actually provide direct clinical services. That's not within the purview of this particular scope of strategy. The other piece that's not included is insurance payment issues. That's also part of those other agencies, and they weren't part of this particular prevention and control-focused strategy. So you will not find those, but nevertheless extremely important. And they have reviewed our strategy, those agencies, and understand that if they wanted a complementary addendum to this strategy, we'd be more than happy to work with them on that. Next slide. So the vision and mission, we tried to keep it clean and crisp. The vision, a nation where vector-borne disease no longer threatens human health and well-being, and the mission is to protect people from illness, suffering, and death due to vector-borne diseases. Next slide. I'm going to go goal by goal. So in the top left hand there, you'll see our shorthand. So the first goal is to better understand when, where, and how people are exposed to and become sick or die from vector-borne diseases. This is our learning. This is when things are emerging and we're trying to better understand a vector-borne disease. You come to goal 1. There are 3 strategic priorities that I won't read to you, but those are meant to help us drive towards that goal. Next slide. Goal 2 is our diagnostics goal. I saw a whole lot of attention in the room to goal 2 over there. People are really honed in on better diagnostics, and we agree. Goal 2 is to develop, evaluate, and improve tools, methods, and guidance to diagnose vector-borne diseases, and we have 4 strategic priorities under that. We will look, and the work that you'll do today will be to help us prioritize among the priorities, but in the room here I see a ton of focus on strategic priority 2, which is develop, evaluate, and improve diagnostic tests for vector-borne diseases and vector-borne disease pathogens. So really interesting to see the why behind that, and I can already hear some of your comments because I've heard them before. Goal 3, next slide, thank you, is our prevention goal. And this is to develop, evaluate, and improve tools, methods, and guidance to prevent and control vector-borne diseases. We have a total of 4 strategic priorities under that. Next slide is goal 4. This is our treatment goal. And as I mentioned, The provision of services is not included in this strategy, but certainly identifying better treatments, develop and assess drugs and treatment strategies for vector-borne diseases is certainly within the purview. And also making recommendations when new options come out. So if NIH has funded research that develops better drugs and treatments for vector-borne diseases, we see that in the literature. We then at CDC pick that up and write guidance to tell the public and clinicians, this is a new evidence-based recommended treatment, and here are the protocols and guidelines for how to implement those treatments. So that is goal 4, and we have 3 strategic priorities there. And finally, implement, goal 5. Disseminate and implement the public health tools, programs, and collaborations to prevent, detect, diagnose, and respond to vector-borne disease threats. And that's basically develop programs to do everything from goals 1 through 4. And we know that this is where the rubber hits the road. This is giving money out to jurisdictions to develop those vector-borne disease programs. It is developing new programs that can increase our reach out into communities. This is where the work gets done out in the community. So next slide. We also have a set of 4 key public health outcomes. They're not all the public health outcomes, obviously, because we have over 100 vector-borne disease pathogens that we have to, at CDC, monitor, detect, respond to. But these 4 really rise above the others in terms of direct impact and volume of cases that we see. And so we identified these 4 public health outcomes as a group across the federal members. The first is to eliminate deaths from Rocky Mountain spotted fever in Arizona tribal communities by 2025. This is the most narrow of our health outcomes, but it's also something that we feel is achievable and addresses a community that experiences 150 times the incidence of RMSF compared to any other community in the United States. So really important. We have a prevention strategy that's evidence-based, it's working, and we're really excited to hear from Dr. Gil Kirsch, who's going to update us on this outcome during the lightning talks. The second is to eliminate sustained local spread of dengue by 2035. Now, you may have heard that I said that we have a program-led dengue response that we just stood up at CDC. We're really worried about dengue, and there are some options, there's some prevention strategies that are coming online. We need to do something here, and it is not going to be easy. These 4 strategic public health outcomes make us sweat. Lyle and I lose sleep overnight at night trying to figure out how we're going to do this. But this is really important, and we have to respond. The next is reduce the number of Lyme disease cases that are laboratory confirmed by 25%, because that's what we can measure, laboratory confirmed Lyme, by 2035 compared to 2022. Another massive reach goal. If you have seen the trends in Lyme disease, you know, I mean, this is going to be exceptionally difficult. It's going to rely upon a number of prevention strategies, vector control, vaccine, more communication, and new tools that we do not yet have in hand to achieve this, but we are committed to it. And finally, reduce the annual number of West Nile virus neuroinvasive disease cases to below 500 by 2035. Absolutely essential to protect people and stop illness and death that can really dramatically change the course of a person's life through neuroinvasive disease. Next slide. In the national strategy, we have a number of visuals that we thought collectively demonstrate something really important. And the first is the reemergence of locally transmitted malaria in the United States. We hadn't had a locally transmitted malaria case in over 20 years until last year when we saw this 7 cases in Florida, a case in Texas, a case in Maryland, and a case in Arkansas. This really worries us. What is changing in the environment, in the community? The risk factors are changing, and we're seeing different patterns. Next slide. We also have this visual that shows the rapid identification and emergence of new tick-borne disease pathogens. We are now just not focusing on a small set of tick-borne disease pathogens. We're having more and more compounding the public health workforce, and every one of these that is emerging has to come to the attention of the public health officials. And so this is a reflection of that. Next slide. and then for mosquito-borne pathogens. Again, fewer emerging in recent years that are new to us, but nevertheless have really, really taken us by storm, and we've had to launch large responses. I think the only reason we didn't stand up a larger response for chikungunya virus was that Ebola was happening at the same time and really took the attention. And I mentioned competing priorities earlier. We in the division are committed, and the 17 federal agencies are committed to these diseases, despite what else is also happening. Next slide. So looking forward, successful implementation of this strategy is really going to depend on all of us working together. We know this was a strategy that was developed by the federal agencies, but it is for the community. It's for all of you, and we need to rely on you to make sure that this is successful. So I hope you see yourselves in this network map. Dr. Kristen Honey, who is my partner in crime on the national strategy from HHS, is going to talk a little bit more about that. But we are really grateful that you're here representing all of these groups. And we're really looking forward to hearing from you as we inform future implementation plans. Next slide. So a final thank you to our collaborators. Next slide, as we move into the goals for today. So our goal is to build community. That's number one always, because I think it helps us do our job better. To network and share lived experience, because that really helps us stay focused on who we are helping, who we are serving, what we are trying to optimize, and what we're trying to promote, and what we're trying to prevent. We also want to collect your individual expert opinions. We're not looking for consensus. This is not a federal advisory committee group. We want to hear from you individually, and you're at really diverse tables, so you will probably disagree, and that's totally fine, and the facilitators who are at each table are there to capture those individual expert opinions. And we want you to give us the sort of relative weight you would place on the 19 strategic priorities, because we have a finite amount of resource. And so when you think about that, how would you spread if you had, your stickers, your dots, our resource? Where would you put that resource if you had your way? And we want to hear from you on that. And all of this feedback will be assembled by MITRE and CODE, who are helping us capture your feedback to inform future implementation plans. So my promise to you is that I will carry the summaries back to the 17 federal agencies to help them think through how are we going to implement this strategic plan, and where are we going to put your feedback and build it into the implementation plans. So with that, next slide. We had a couple of more results from the engagement tool that 50 of you completed. This is the relative expertise that you have. I'm not sure why it says vectors represented, but ignore that. These were the topic areas of which you said you had that were relevant to you. So we know Lyme disease is very relevant to most of you, babesiosis, the spotted fever, group rickettsiosis, West Nile, Zika, malaria, dengue, and then others, which we'll look at carefully, and a few long COVID. Next slide. And the relevance of goals. Which of the following goals of the strategy do you consider most relevant from your perspective? And you can see, really, they all are pretty relevant, which is good. That's what we would hope. And sort of the leaders up there, goal 2, our diagnosis goal, and goal 5, our implementation, followed really closely behind by our prevention goal. But all of them are important. We will implement activities that address all 5 goals. That's our commitment to you. And with that, I'll hand it over to Dr. Kristen Honey. Next slide. Thank you. So you can stay right there. If you can go back one, perfect. And then we'll get you teed up for our lightning talks.
Thanks, Sue, and thank you, all of you, for being here and lending your time, talents, and energy spoons to today. Both the virtual people watching and participating and those in the room, we recognize it takes a lot for a full day, so thank you. And I want to start by just, I love this African proverb about never underestimating the power of one. So the quote is, if you think you are too small to make a difference, you haven't spent a night with a mosquito. Similarly, Margaret Mead had never underestimate the power of a small group of committed people to change the world. In fact, it is the only thing that ever has. And I want you all to realize how much this field has changed in a short amount of time because of you. And today's format, how we're crowdsourcing priorities, and where would you put your dots if there were limited resources, that actually was inspired by the Lyme community many years ago. LymeDisease.org between 2015 and 2017 had a crowdsourcing exercise of give us the top 10, let's crowdsource the top 10 Lyme scientific research priorities. And from that movement, diagnostics emerged, but like it was the bottom up. Let's hear from many, many people and wrangle all these anecdotes, all these individual perspectives into a group and the wisdom of the crowd, the power of the crowd, so it can be data that's easier for policymakers to respond to. We have not done one of these crowdsourcing exercises with HHS in about 6 years. After the first tick-borne disease working group report, many thanks to the designated federal officer, Jim Berger, in the back, when that 2018 report came out, HHS and the executive branch mobilized and Congress mobilized. A direct result was the Kay-Hagan Tick Act passing, which created all the authorities for us at HHS and the 17 agencies to collaborate, convene, and begin implementing these solutions. Also out of the tick-borne disease working group, a roundtable that many of you probably participated in happened in this room. And we wanted to hear what are the near-term things that we all can do, all sectors, to move the needle on Lyme. Actions taken in the next 3 to 6 months that would change the trajectory of this field. And what arose from that? We need public-private partnerships, because getting government budgets, getting new programs can take years, and people do not have years to wait. So to catalyze things and get things moving now, let's start public-private partnerships. Your idea turned into the world's biggest public-private partnership between HHS and the Stephen and Alexander Cohen Foundation. Many thanks to Ben Nemser over there. So thank you, Stephen and Alexander Cohen Foundation, Ben Nemser, for your leadership. But that idea came from a roundtable here. Another idea was diagnostics. How do you move the needle on diagnostics that haven't changed in decades? Likely technologies exist in other diseases that could be repurposed for Lyme disease. How do you attract that science to this field? The idea of grand prize challenges came up. Could we run a diagnostic prize, only pay for performance? Maybe oncologists or other precision technologies that haven't thought of Lyme and tick-borne illness might engage. That LymeX diagnostics prize that's now in its 3rd phase happened because of ideas in this room. So today, we're back here today, many years later. The ecosystem has changed a lot, and we want to hear your individual ideas for the next phase of efforts. And I'll say rarely in government or in any large organizations do you have an inflection point where you can change the trajectory of future work, future budgets, and priorities of that large group. This, today, both virtually and in the room, is one of those inflection points. All of your input will be shaping the implementation of this brand new, first ever national strategy for vector-borne diseases. So I strongly encourage you to put your dots on, give us your feedback. And how government works best is when you have concrete asks of us, and ask in a concrete way, you want this website changed, here this science supporting it by this date, or you want this continuing medical education material to be updated, here's the science. HHS, and we're only one agency of many in this federal strategy, is 90,000 people, and that doesn't include contractors. We're a large organization. So we're hoping today that we can help demystify this massive organization. And you know Sue at CDC, myself at headquarters, Leith at headquarters. We're demystifying here because government is made of people. And if you can talk to the people and get clear what's needed, how can we improve policy, latest science, education materials, And we can help you navigate to the right places. I think that changing government in large organization is, what do you want? What's the replacement? And who controls that? And so think of us as collaborators, co-creators on the solutions. Come to us. If you don't know who in government owns this, we'll help you figure that out, and together we'll solve it. You will notice from the slides that Sue shared that we're going beyond Lyme disease, and far beyond Lyme disease. And that actually is a strength, to pull on what other disciplines, what other diseases, other fields have done with success. So there were people here with long COVID, infection-associated chronic illnesses, many vector-borne diseases. So learn across each other, because that exchange can really be valuable. And there are still disagreements. We've heard that. We're moving forward together. We've improved the field drastically for all of those who are in the arena, on the field, rolling up their sleeves and working with us. But where there's controversy, we should remember we need more data. Take it as a signal that where there's controversy, we need more science, we need more data, and science will be our way out. But science sometimes takes time. Quality science does take time. And so we can do both. We can advance the science while supporting those who need solutions today. So with that, I would encourage everyone to get specific with your request, as specific as you can, and speak truth to power. Because this is your opportunity to roll up ideas, individual ideas, and give it to us straight. Because if we in government don't know what the challenges are, we can't solve them. And you all on the front lines know those problems better than anyone else. So tell it to us candidly. And as Sue said, you have our commitment that we will ingest this, we will take it, and we will do our very best to respond to it. And the last thing I'll say is thank you all for showing up. I know there's a lot of skepticism in the community that government can help. And for all of you who are in the arena with us, I want to just thank you for being here, for showing up and working with us. And one thing I like to say is that it's hard to throw rocks and roll up your sleeves at the same time. So thank you to everyone, both online and in the room, for rolling up your sleeves with us. Let's co-create solutions together.
Excellent. Thank you so much, Kristen. So now we're going to go into a series of lightning talks. They're 5-minute snapshot talks that really spotlight progress that has been made last year or in very recent years. We're really excited to have them. We're going to start with Dr. Deshotels. Daniel will come to the stage, followed by a flea control and interpretive education at Badlands National Park presentation, one on mill tick, emergence of the longhorn tick, and then closing it out with a spotlight on one of our target outcomes, Rocky Mountain spotted fever in tribal communities of Arizona. With that, I'll hand it over to Daniel.
Okay. Next slide, please. Thank you, everyone, for being here. It is my pleasure to welcome you to HHS here, and we're all very excited, as everyone said, to hear your opinions on this strategy. Next slide, please. Next slide. Yes. So, as Sue introduced, my name is Daniel Deshotels. I am a health scientist here in the Office of the Assistant Secretary for Health at the Department of Health and Human Services. And today I'm going to talk about something that, as is evident in the room here, is very important to everyone, is better diagnostics. So, as many here in the room and online know, Lyme disease is the most common vector-borne disease in the United States. And unfortunately, there have not been any major breakthroughs in diagnostics in Lyme disease in over 25 years. And given that early diagnosis is critical to treating people and making sure that people don't develop long-term issues, it's just not acceptable that there haven't been these innovations. And so, because of this complex problem, there's an opportunity to use what Dr. Honey had introduced, a multi-phase, multi-year prize competition to accelerate possibly unknown innovations and bring them into the forefront so that they can actually be implemented and help people now. So, as part of the LymeX partnership that Dr. Honey talked about, and yes, Stephen Alexander Cohen Foundation, Dr. Ben Nemzer is here in the audience today. this public-private partnership launched the LymeX Diagnostics Prize Competition. And so this is a multi-phase, multi-year prize competition to identify innovative Lyme diagnostics and accelerate them towards FDA review so that they can actually be used in Lyme disease diagnosis and prevention. And so kind of what we did here, we started with a Lyme disease diagnostics testing request for information where we got responses from the public saying, yes, this is important, and here's something that we would like to see. So after HHS and the Stephen and Alexandra Cohen Foundation developed this prize competition, in May 2022, we launched the LymeX Diagnostics Prize Phase 1. And this was an open call for submissions, a paper stating what is the kind of diagnostic that you would want to create. And so we had 52 wonderful submissions, and after judging, there were 10 winners who shared a prize pool of $1 million. After that, those winners were invited into Phase 2, which was the next year in 2023. And so these 10 teams underwent an accelerator to get subject matter expertise from experts in diagnostics, biorepository, sample operations, and other pieces of information that would really help them accelerate those diagnostics, something that they might not already know. And so after going through this accelerator, 5 winners were identified, and they shared a prize pool of $2 million. So we're very excited about the progress here, and Phase 3 is currently underway, being mainly run by the Stephen Alexandra Cohen Foundation. So you can head to that website right there to learn more about the past winners and kind of updates on the diagnostics. But I hope that you can all see this is working on Goal 2 of the National Strategy for Better Diagnostics, and thank you all today for this talk.
Good morning, everybody. Hope everybody's doing good. As Sue noted earlier, I think she might have mentioned, my name's David Eads, and I'm an ecologist with the U.S. Geological Survey in Fort Collins Science Center in Fort Collins, Colorado. And to start, we'd like to thank the organizers and everyone here and everybody online for the opportunity to present a little bit of our research today. This is brand new for me. This is really cool, and I'm excited. Thank you so much. The following story that we're going to get into is relatively short, but hopefully entertaining, and it relates to sylvatic plague, a disease caused by the flea-borne bacterium Yersinia pestis. This is a bacterium that poses a risk to people and wildlife, causing social strife and ecological problems throughout much of Earth, and in some cases it can even transform ecosystems. And so I'm here today to talk about plague, mainly in relation to wildlife conservation and ecosystem functioning. If we could go to the next slide, please. In recent years, this presentation is going to concentrate on a project that we completed at Badlands National Park in South Dakota. In recent years at Badlands National Park, there was a need to identify a plague mitigation strategy for flea control with insecticides that could be used to address One Health objectives while reducing human exposure to flea control tools, such as insecticides that we used in this case. Next slide, please. So the U.S. Geological Survey and the National Park Service embarked on our project with many different partners, including the CDC and others that are here today. And we attempted to combine One Health messaging and flea control under a highly collaborative framework. Specifically, we tested a flea control medicine, in this case an EPA-approved grain bait with fipronil, active ingredient for flea control. And prior development of this bait was actually funded under a grant from the DoD's Deployed Warfighter Protection Program. Generally speaking, the research demonstrated that this fipronil grain product was highly effective in flea control with prairie dogs during periods of peak human visitation at the park, primarily at a campground where we conducted this research. We found very few fleas from prairie dogs and very few fleas in their burrows on treated areas that were used by campers, including burrows that were adjacent to tents where we observed prairie dogs that were sometimes even entering those tents and going inside perhaps in search of food, And on a few occasions, we had some rain events where some water accumulated next to those tents and along the edges of the tents, and the prairie dogs were going up and gathering water, which is pretty limited in their grassland habitats, and that brought them into close contact with the campers there. But luckily, the treatment worked out for flea control. Interactions with park visitors were generally positive and educational. You saw a picture a moment ago of 3 sisters talking with one of our teammates out on the prairie dog colony where we worked, and hopefully kind of the expressions on their faces helped to illustrate the excitement and joy that we saw in visitors during this research. Overall, this study helps to illustrate the National Park Service's efforts with many partners, including the USGS, DOD, EPA, and others to confront disease risks. And also, it's important to note that this research has informed efforts to conserve prairie dogs and their endangered predators, black-footed ferrets, one of which is depicted here. This is a maternal female ferret with her prey, a juvenile prairie dog, in her mouth. And these are highly endangered carnivores here in the western United States, one of the most endangered mammals on Earth. So hopefully this research is helping to inform efforts to conserve them. This research has also resulted in additional collaborations and discussions on mosquito-borne diseases. And so some of the presentations today here, the lightning talks, may not talk about mosquitoes very much, but the organizers wanted me to emphasize in this presentation that this is leading to mosquito-borne disease mitigation, potentially with fipronil in different forms. Could we go to the last slide, please? Here's some resources that may be of interest to the group. Everybody online will have access to these, and I'm sure later on we'll have access to these slides. And again, I'd like to thank everybody here and everybody joining virtually for the opportunity to present. And thank you to all of you for your contributions to inform the Vector-Borne Disease National Strategy. Thank you so much.
Good morning, everyone. I would like to give a special thanks to Dr. Gabby Zollner for inviting me to speak today, along with HHS, the CDC, and CODE for hosting this event and also allowing me to speak to you all. My name is Dr. Jessica Jones. I'm a parasitologist at the Vector-Borne Disease Branch at the Defense Centers for Public Health, Aberdeen. Can you tell I work for the government? I'm here to tell you today about our MILTIC program. Next slide, please. Legal disclaimer, again, federal employee. Next slide. So why does the DoD care about ticks and tick-borne diseases? Because DoD service members are routinely exposed to tick bites in course of their official duties. Tick-borne diseases often manifest with nonspecific symptoms and can be both difficult to diagnose and to treat. Tick-borne diseases can also result in service members being unable to be deployed, being medically discharged, and overall reduces mission readiness. So the DoD required a tool to evaluate tick-borne diseases and the risks associated with tick bites and provide actionable results to service members and other DoD beneficiaries. So the DoD also required routine surveillance conducting on the military installations, also required to assess changing tick-borne disease risks to military communities. Next slide. So in 1995, the DoD implemented the Human Tick Test Kit program, recently rebranded to our acronym MILTIC. That stands for the Military Tick Identification Infection Confirmation Kit. So the MILTIC program provides free tick testing services to service members and any DoD beneficiaries. So human-biting ticks are received to us and identified to species and tested for medically relevant pathogens, and in turn, the submittee receives an electronic report and describes the associated risks with that tick bite and any tick-borne pathogens that were detected. This information serves as a diagnostic tool and a first alert to the submitter to be used by medical providers to better diagnose and treat these tick-borne diseases. MILTIC also actively screens tick samples for rare and emerging tick-borne diseases, and the data generated serves as a passive surveillance system of emerging tick-borne disease threats at military installations and beyond. Next slide. So over the last 30 years, yes, this program is as old as I am, MILTIC has tested over 60,000 human-biting ticks from DoD service members and their beneficiaries. Nearly 8% of those ticks that we've tested have been positive for more than one of the 20 routinely tested tick-borne pathogens. These pathogens include the bacteria that causes Lyme disease, spotted fever group rickettsiosis, and also ehrlichiosis. On this screen here, you can see a screenshot of our data dashboard that is CAC-enabled. And what this shows us is just a visualization of where those ticks are submitted to us and where those disease risks that we have interpreted are from a geographic perspective. This data dashboard is updated monthly, and it enables near real-time decision-making by senior leaders to mitigate these tick-borne disease risks. Miltic data are also utilized by clinicians to help diagnose lesser tick-borne diseases such as ehrlichiosis. If you want to hear more about that, you can ask me later. Miltic surveillance data are also routinely published and have been utilized to identify hotspots of emerging tick-borne diseases. So Miltic as a whole continues to support service members and DoD beneficiaries through the testing of human-biting ticks for medically relevant pathogens in an actionable turnaround time. Next slide, please. So this is just showing us our links. So here you can see our email address, the website for our public-facing website, which also encodes our information, and then that last link is showing us that interactive data dashboard that you had seen on the previous slide. Also, I brought some of our handy-dandy tick kits with me today, so over next to the snacks, you can see our information sheets. Feel free to take one or as many as you want. I also brought some business cards with me if you would like to order some more tick kits. Again, completely free service. And with that, feel free to find me at a break, and I will answer any of your questions. Thank you.
Good morning. My name is William Nicholson, and I am the team lead for ecology and entomology at the Rickettsial Zoonoses branch at CDC in Atlanta. We work with Denise Bonilla and her team at USDA to monitor the Asian longhorn tick, Haemaphysalis longicornis, and to assess its importance to livestock, wildlife, and humans. My goal this morning is to update you on the current status of this tick, its distribution, and its ability to transmit both human and veterinary pathogens. Next slide, please. The longhorn tick was first discovered on a sheep in New Jersey in 2017. Further review of archived specimens found that this tick had actually gone undetected in the United States since 2010. In other countries of the world, this tick serves as an important vector of a number of human and animal diseases, including the potentially fatal severe fever with thrombocytopenia virus, which is now known as Davy Banda virus. Although this was a native of Asia, this tick invaded New Zealand and Australia and has become a major livestock pest there. USDA Animal and Plant Inspection Service led the coordinating efforts with a range of state and federal agricultural and public health agencies to begin surveillance for this tick. They implemented enhanced vector and animal surveillance as a proactive measure to detect further tick infestations. Today, this network has 385 members from 36 states and Canada. To date, surveillance efforts have confirmed local longhorn tick populations in 19 states and 234 counties. Of these, 110 counties have established populations of this tick, as shown in the darker blue color here on the map. This tick feeds on a wide range of domestic and wild hosts, as well as humans. This is a valuable information for future control efforts, and as of April 2024, the USDA has started a web page to provide educational material on this tick and is developing a dashboard, and you can see the address here in the lower left corner. Next slide. CDC and NIH undertook comprehensive studies to ascertain whether the longhorn tick had the capacity to transmit medically important pathogens. A number of stakeholders at universities, health departments, and state agriculture officials began to test the ticks for pathogens. No cases of illness in humans has yet been linked to this tick in the United States. Lab studies have shown that this tick cannot transmit Borrelia burgdorferi, which causes Lyme disease. However, studies have shown that these ticks can transmit Rickettsia rickettsiae, which is the causative agent of Rocky Mountain spotted fever, heartland virus, Powassan virus, and the animal pathogen Talaria orientalis akita, which causes cattle tulariosis. Efforts to survey the natural tick population for pathogens has continued. It has become very clear that this tick is extremely important to livestock through blood loss and transmission of Talaria. These coordinated efforts by many organizations have led us to a better understanding of the tick's distribution and its potential for transmission of both medical and veterinary pathogens. I hope this short review has been useful to you. Next slide. Here's a few resources. Thanks for the opportunity to provide this update, and I look forward to the discussion during our roundtables. Thanks.
Hi, I'm Gil Kirsch from the Rickettsiozoonoses branch at CDC. And as you heard, things are bad and they're only getting worse. And into this pool of despair, I'd like to throw what's maybe a glimmer of hope. And this comes from an unlikely source, which is Rocky Mountain spotted fever. If I could have the next slide. So I'll refer to this as RMSF. And this is a potentially fatal tick-borne disease that's found all across the Americas. It's a devastating disease that can have case fatality rates as high as 50%. And many people who survive the disease have long-term impacts. The good news is RMSF is treatable with antibiotics, and patients can recover quickly and fully if the disease is recognized and treated early in the infection. Could I have the next slide, please? In 2003, RMSF was recognized in a tribal community in Arizona where it was found to be transmitted by the brown dog tick, a previously unrecognized vector for this disease. And over the last 20 years, over 500 cases of RMSF have been reported from 6 Arizona tribal communities. And there have been 28 deaths from the disease there. The problem was at its worst around 2011, a year with more than 50 cases that included 6 fatalities in very close-knit tribal communities. And so at that time, the incidence on the tribal lands was 150 times the national incidence for spotted fevers, and children were heavily impacted. Factors that contributed to this situation included large populations of free-roaming dogs, massive numbers of brown dog ticks, and the presence of the bacteria that causes the disease, Rickettsia rickettsii. Poor housing conditions, limited access to veterinary care, and lack of knowledge about RMSF in the community made the problem difficult to solve. This is not a problem with thousands of cases. However, in these communities that are not very large, the incidence is very high, and we consider this at its heart really an issue of health equity, where populations with low resources are impacted heavily by a disease that can be treated and prevented. So next slide, please. So in response to this, in 2012, the CDC demonstrated that tick control on dogs combined with community and healthcare provider education can reduce cases and deaths due to Rocky Mountain spotted fever. In 2018, CDC initiated a One Health collaborative model with the tribes, the state health department, and other partners in applying prevention methods, which include treating dogs with collars that kill ticks, applying pesticides to homes, and ongoing community education. CDC has enabled tribes to set up animal and vector control services and has worked with partners to improve veterinary care in the communities. Next slide, please. So these efforts have resulted in a reduction in cases of RMSF in these tribal communities, and an average of only 23 cases reported each year since 2021, and only one tribe reporting cases in 2023. And importantly, there have not been any reports of death due to RMSF in Arizona's tribal communities since 2019. So we view this as a success, and this can be attributed to the close collaborations developed with tribal communities over the years. And this has enabled the implementation of prevention efforts tailored to specific communities where they're needed. And this is not all just historical documentation. I'd like to highlight some specific activities carried out just in 2023. We had 8 RMSF prevention campaigns that were hosted by 3 of the impacted tribes, and with CDC staff providing in-person support for all 8 of these campaigns. And this resulted in treating over 6,800 homes for ticks and treating 4,900 dogs. And additionally, the 2 most highly impacted tribes administered community surveys on knowledge, attitudes, and practice associated with animal wellness and RMSF. CDC has worked alongside partners with the Arizona Department of Health Services to host a statewide RMSF meeting in 2023, and this was the first one held since 2019. And there were 73 attendees representing 8 tribes in Arizona at this meeting to share best practices about RMSF prevention. CDC also assisted canine wellness campaigns alongside rural area veterinary services and the Arizona Humane Society. And CDC medical officers coordinated with tribal health partners to conduct 3 seminars on diagnosis and treatment of RMSF. So these efforts have resulted in good news for one of the targeted public health outcomes in the national strategy, and that is to eliminate deaths on tribal lands due to RMSF. So while we've had success in the short term, there's still more work to do. Some tribes continue to need financial and technical support to carry out RMSF prevention. But importantly, these are activities that are led at the local level with buy-in from the community, and CDC provides support. And with continuing collaborative efforts, we plan to assist tribal communities in Arizona to reduce RMSF to less than 10 cases per year, and ensure that any cases that do occur get recognized early and receive rapid and appropriate treatment. So next slide. And I'll turn it back over to Sue.
All right. Thank you so much to Daniel, David, Jessica, William, and Gil for those lightning talks. I hope you heard tons of collaboration across the federal agencies, a smattering of focus across a bunch of different vector-borne diseases, and a lot of community engagement throughout. So hopefully that will, get your juices flowing cognitively around what's possible and what we hope to do together in the future. We're going to take about a 5-minute break as we transition from dropping the live stream and then focusing in on your tables here in the room, the Zoom rooms, online. There was a QR code that was flashed up, if you could put that back just really quickly. For those on live stream who would like to receive a summary of the event later on, everyone who is engaged as participants will receive this. But if you're out there in the world and would like to continue to receive information from us, please go to this link so that we can get your email and we can continue to communicate with you. And with that, I'm going to close us for the live stream, give you about 5 minutes to take a quick break, and then Joel will join us and help us transition into the activities today. Thank you so much. So, welcome back. I believe the live stream has restarted, and so we have many people from across the nation joining us to hear what you all have been up to, both in the Zoom rooms and at the tables. In Zoom, they were doing all the same things that you were doing at the table in groups of 10 to 12 or so. And so I'm really excited to hear, this is going to be so tough on the facilitators. They're going to come up and give a little 2-minute summary of what happened at each table or Zoom room. Before that, what I thought I would do is give a quick glimpse into what you all did at the very front end of the meeting, which was to do the dot activity across the goals and the strategic priorities. Did the same thing in the Zoom rooms. And so Gabe was awesome and created a visual for me to show you what that looked like before you had your discussions. And boy, you guys are really focused in on diagnostics across the board. And what's really cool is in person or virtual, and obviously there was no rhyme or reason to that. It was just how people could attend. Super consistent, really across the distribution in both settings, with a great dominance on we really need better diagnostics for vector-borne diseases. And especially strategic priority 2, which is really developing those new diagnostic tools. Resounding predominance of focus. And that's good news in that we have the LIMEX initiative that you heard about earlier today. At CDC, we are focusing on better diagnostics across a number of vector-borne diseases. And we're hearing from you, we need to do more of that. So really, really great to see that. And then a cascade of priorities across the other goals and strategic priorities. We'll be digging into everything that you did at your tables. We expect this will be the same pattern based on what you did when you had a little bit more time to think and discuss. And we captured the why at the tables. And so we will be taking that information and really, really digging into it to understand the why behind where you placed your emphasis. But to try to help summarize and get a feel for what happened today, we're going to turn it over to the facilitators. And we'll start with the in-room facilitators and then move to the Zoom rooms. Joel.
Thank you, Sue. So we are going to go in, we're going to be very creative and go in the numerical order of the tables, except that I'm going to jump the line since I'm up here already, Liz, if that's okay. I'm table 2. And I am urging, we really do, we have 12 different tables, all of which I think had fantastic discussions today. So I am urging my fellow facilitators, please do something like this. Self-time, and we will keep this to 2 minutes apiece. And I'm starting now. So we had a fantastic table that really just touched on all kinds of issues. I think some of the major themes, and then I'll go into a little bit more detail, which is, a lot within the realm of diagnosis, a lot of focus on early detection so that treatment can begin earlier, but at the same time with a real emphasis that it's also critically important to help people who already have been chronically infected and who have been living with and dealing with these diseases for a long time already. A lot of focus on physician and clinician education. And this sort of came up in a couple of places in the goals, particularly around terminology around guidelines, things like that, but really a sense that they need the folks who are clinicians in this area or even primary care people, need just much more education and much more knowledge than they have now. A lot of focus on the need for a vaccine, a lot of discussion of how we balance different kinds of vector-borne diseases, that it's really important to focus on emerging threats, but at the same time to keep a focus on Lyme and the ones that are already affecting so many people as well. big focus on the need to really track how the strategy is implemented with a real commitment to accountability, timelines, deadlines, measurable outcomes, and so on. A lot of focus on maintaining this kind of inclusive discussion, including with people who maybe were not able to be here today. And then I think a big focus on the importance of data and evidence, which goes sort of like we need better diagnosis to get better data, we need better clinical and surveillance data to develop better intervention strategies, and we then need to track the efficacy of those strategies as they play out. 1 second left. Thank you all.
Good afternoon. So I represent Table 1. I'd like to share a couple of themes that we had across the 5 goals. The first was around communication. And a lot of this spoke to being audience-specific in how we message both prevention and treatment and the follow-up care for patients. We also talked a lot about data sharing. Even though this was in Goal 1, it came through in quite a few of the other goals. Regulations also came up, although in Goal 4, we heard it even in Goal 2. And then finally, funding. All of these came across as themes in each goal discussion. The second point I'd like to make is to pay attention to innovation and embrace it. This also includes collaboration with industry. We were really beneficial. It was really great that we had an industry representative at our table. And part of that is in making sure that we understand the impact of regulation on industry and their end-to-end commercialization, especially of diagnostics. And then finally, a strong theme in our table was around harmonizing across existing organizations. It is possible that there's a solution out there, and it's connecting these existing organizations to be able to share and possibly scale that solution, such as education for K through 12 that's already happening in Syracuse. Thank you.
Hi there, I'm Gretchen. I'm here to represent Table 2. They could do so much better than I can, but I think that what we would like to share is that you're looking at individuals as a whole, you know, not just as a physical thing that's happening to them from a vector disease, but from the mental, the physical, the psychological, everything that's happening, and make sure that that you look at all treatments and options from that viewpoint, from an individualized viewpoint. And to that end as well, communication was a big piece that we were talking about as well, and you know, making sure that it is idealized for the audience that needs to use that information, and that coming from the federal government as an imprimatur to the localized government will help emphasize the importance of that messaging as well. It's truly looking at things from an equity lens, you know, thinking, you know, it's different for every individual, it's different for every community, and treating each community with respect will be able to work this a little bit better, because you're working together with people that you wouldn't typically work with to find that solution. And we've got a lot more than that, but I think that boiling the ocean to trying to get to that, thinking of a lens from an individual as much as from a large, you know, disease state is probably the important thing for us to take away.
Good afternoon, everyone. I represent Table 4, and I'm actually just going to time myself really quickly. So we had a great conversation at Table 4, and I think kind of going around at the end of the day, which was always music to my ears, was hearing this theme of collaboration and kind of being surprised by folks, what they had in common in the room. I think it's really common for a lot of folks to feel they come from their own little silos, but having those conversations, there was a lot of shared interest in kind of moving this ball forward. So that was really, really nice to kind of start with. Our table was really focused on prevention. I think that was really one of the big themes that stood out from the day, was that by really prioritizing those strategic priorities under the prevention, you'll avoid having to get to any public health emergencies or address it. If you can stop it before it gets out the gate, resource-wise, it's cost savings, it helps people, and it's valuable. And with that, the education piece was really highlighted as well as being quite important, and especially with the CDC, it being at the helm, kind of the authoritative source, that's really critical to make sure communications-wise they can get out. Surveillance systems and that specific strategic priority around surveillance, we had a long conversation around that, was definitely flagged as being kind of maintaining and promoting that was really important. We also were trying to also think a little bit about this around, in terms of implementation, what can the federal government do, right? This is sort of a limiting factor. A lot of this stuff is going to be in that purview, so what are the kinds of options on the table? And so in areas like diagnostics, or areas where there isn't as much of that market or industry incentive to build out for specific smaller acute diseases, that's really where building out guidelines, nudging the ball can really make a difference. And we did talk a little bit about acute versus long-term, and really needing more research there as being important. And data and evidence was also flagged as a really big one. And then last, I think, a couple more points, building workforce capacity was really, especially with a changing environment, the climate shifting, kind of having more folks who are prepared to get into this is important. And I have 10 seconds left, so I'm going to stop there. Thanks, everyone.
Okay, first, thanks for Table 5 for the great discussion, really great insights, and really appreciate you all being here today. I'm going to do my best to organize those into a few bullet points. I think the first thing was everything is interconnected, specifically the goals are interconnected. They're all important, and it's really important for that reason to collaborate across groups, across the people in this room and elsewhere. I think another big thing that came up as Sue, we learned from Sue earlier today, things have not necessarily gotten better. The progress has been slow. So there's a few things to that point. One is just prioritize, human outcomes. This is really important. It's not academic, it's about people. I think the second part of that is just take action, don't stop, keep going. And then the third piece is, the evidence is not perfect right now, but you have to do the best with what's in front of you and what the evidence you have. A couple of other big things, testing, data. I think a few more things stood out. One is just be aware of unintended consequences. Another is guidelines are great, but they need to be sensitive, flexible, and changeable. And then the last one was really interesting, leverage existing efforts and overlaps. So there's a really interesting example of lots of people getting carpal tunnel surgery in one area, maybe tests for tick-borne diseases, things like that. They're out there. We had a couple good highlights of that. So I hope I stuck to 2 minutes, and thanks a lot.
Hi, Ariel Marshall, representing us all the way at the back at Table 6. We had also a wonderful conversation which addressed many of the same topics and themes that we heard from the other facilitators, specifically a need for collaboration and viewing tick-borne disease, specifically tick-borne disease and other vectors as a collaboration among multiple stakeholders. The need for research and better diagnostics and treatment, and the need for education for public health officials to educate public as well as physicians and train them on what exactly all of this means. Also, there was a lot on the need to evaluate and standardize current funding methodologies and diagnoses, treatment, and everything else. There was also a common theme of perinatal transmission of Lyme disease, that it needs to be elevated to an issue of public health importance and research significance to have more funding and attention there. Thank you.
Going to go now to our online group. Yeah? Great. Manib, I think you are group 7, so please continue.
Yeah, and the first breakout, the virtual breakout room. So can you all hear me? Perfect. So going on behalf of my breakout room and also Temi, who was facilitating alongside me, I think most of the themes that were discussed in our group have already been covered in the in-person discussions. But I would also want to highlight, based on the outcomes from my group, a couple of things. One was specifically regarding improving the testing and diagnostic facilities and methods to make these more sensitive to the vector-borne diseases. I think we have been talking a lot about developing surveillance systems. There was a very good suggestion that came forward of developing an interconnected surveillance systems for vector-borne diseases, which can be also a medium of data sharing between different agencies, different stakeholder groups, whether they are, patients, public health, healthcare professionals. This way, they can even have control over the data tracking and monitoring, and they can have real access to the kind of data they need for surveillance. Apart from that, clinical diagnosis is also an important theme that emerged from the discussion. So, treat every symptom in regard to a vector-borne disease, or at least keep that in mind, because patients often are overlooked, and, something that that starts on from a simple headache may result into a much bigger disease. I think we have spoken a lot about coordination, connectivity between the different partner groups to enable free flow of information and knowledge. Apart from that, there was also the discussion about education, improving the medical education specifically. So, incorporating recommendations from experienced doctors and medical professionals who are actually treating people with vector-borne diseases. That kind of information is required to enhance the educational standards in the medical schools. Apart from that, another recommendation was to provide special care facilities and also tend to the needs of people who have contracted vector-borne diseases. Many of them cannot really go out in public. They cannot avail the public services as other people. So that should be also a consideration. I think and then one very important point was regarding the geographic disparities in identification and treatment. A good example was that West Coast probably is considered less probable of contracting vector-borne diseases, but however, that is not true. So, geographic disparities should be dealt with. I think that's all from my group. Thank you.
Hi, everyone. I'm here representing the 9 of us from Virtual Breakout Room 2. Hello to everyone in person. Yes, there were amazing conversations held virtually across the country, so shout out to all of us online. Plus one to what was said about the appreciation for the interconnectedness, but with that, though, still a higher prioritization on the diagnostics, like folks have been saying. So especially in the earlier stages, early detection. Also plus one to the focus on physician and clinical education. Those were some big pieces. Also hearing another, our group added in an additional emphasis on the role of communication and public communications. As someone said in our group, there's a lot that can be said just right now about where we're at, where our tests are at, the efficacy of our tests before we even move forward with any of these next steps. There's a lot that can be communicated about our current present status. I'll wrap up with a couple more things. There was also a strong alignment within our group that more acknowledgement around gender differences would be beneficial and is currently underappreciated within this work, and that we're working with heterogeneous populations, that we do need individualized solutions. And then lastly, one common theme of something that actually was maybe consistently deprioritized in some sense compared to the other items were less of a focus on emergency response and feeling like we have a lot that we can focus on with what we currently have. So thank you for your time.
Hi, everybody. My name is Alyssa, and I facilitated Breakout Group 3 in the virtual space. Shout out to all my group members and our great note-taker, Lame. I'm going to share 5 what I think are interconnected themes that came up for us. The first is we need better data. And to get better data, we need more standardized surveillance systems across different counties and jurisdictions in the country and beyond. Secondly, with the better data and the clarity that that brings, we need more clear and compelling communications and storytelling, both to reach the broader public and key audiences and partners, which leads me to the third thing, which is the importance of collaboration. So we talked a lot about the need for collaborating with physicians and training programs for physicians, whether that's medical school or lifelong learning opportunities. We also talked about the importance of collaboration with groups like national park staff and international organizations, because we know that border diseases cross borders, right? And to that end, point 4 is really about how national may not be a comprehensive enough approach for the strategy that we know international populations, as well as populations that are most impacted by historical and structural inequities, are often at greatest risk for these diseases. And so given the fluidity of our movements, we need broader and coordinated strategies. And then finally, with all of that clarity that the data and collaborations will bring, we need more intentional and strategic allocation of resources. And so both in the sense of what works and really investing in things that we know and believe will work, and also who and where most needs those resources. So that's it for now. Thank you.
Good afternoon. Happy Friday Eve. So to not be redundant, I will say what they just said. In essence, what everyone has said thus far reflects what our conversation in our breakout virtual room 4 was, with a special shout out to Ezekiel for wonderful note taking. I will say that a running theme, as we talked about takeaways, was a tension between bittersweetness, in that we're really frustrated that we've come so far in terms of time and decades that have passed with treatments and knowledge, yet we haven't seen the progress in the space of treatment and knowledge being reflected in the real-time space of clinical care and the differences that need to be made in the lives of those who are affected. And so when we talked about what we can do, again, very similar to what's been said in terms of education, training, but we also talked about the novel ways to approach this, because clearly we need something new. And so one of the things we discussed was ways to reach people at different audiences in different ways, comedy being one of them, and thinking about different approaches to really get the message out, and to make sure that we understand what we're really looking at so that we can truly move the needle. And so the other big tether of the bittersweetness was that it can be done. We're hopeful that it's possible, that there's education and progress possible, but we have to help move that forward in terms of funding, education, and knowledge. And so that's what I'll share for now. Thanks.
Hi, folks. Happy Thursday afternoon. I'm Jessie Bellama, representing our virtual group 5. And again, a lot of the themes that have already been spoken to, we spoke about in our group. This is a holistic a challenge that we're facing, and we have to have holistic solutions to address it. So it's systems. And so that was really talked about a lot in terms of being able to look at how do we prioritize. The two things that stood out, much like for others, was an emphasis on diagnostics and diagnosis, that we need to know what we're dealing with in order to then be able to roll out the other priorities. And at the same time, for goal number 5 around dissemination and implementation, really communication, that anything we do in the other goals and priorities doesn't really get anywhere if we don't communicate it effectively. And echoing that sense of frustration around vector-borne diseases and tick-borne diseases in particular, or the lower level of knowledge, and how can we be more effective at acquiring and disseminating that knowledge. And then another point on the diagnosis side, really important distinction between detection and diagnosis. So how do we make sure that we make that distinction and carry that forward in sharing that information out, because that's an important distinction for folks who may not be experts in this space. So I'm going to leave it there, and thanks for a fantastic conversation and group.
Hello, my name is Carrie Quinn, and I am bringing up the caboose. Thank you for all of the colleagues that have gone before. A special thanks to Dr. Carrie-Ann Pert for taking notes in our virtual group 6. Really robust conversation, echoing so much of what has been said so far. Team, less hierarchy and more integrated conversations just like this. Funding for the less glamorous side of research, investing in the utility of biobanks for human, veterinary, and vector-related kinds of samples that can be shared in a robust and effective way. Looking at effective models, some of the current models may not be what is needed in order to best support diagnosis, treatment, anticipation, etc. Like others have said, involving the clinicians. So in addition to researchers and academics, people who are on the front lines diagnosing and treating, engaging with patient populations, maybe lowering the burden of bureaucracy to get effective vaccines and treatments into the pipeline and out where they're useful, and being mindful of innovation, that we are up to date and using the most relevant scientific information to support treatments and vaccines with less severe consequences to the people who need them the most.
Great. Well, hats off to our facilitators for doing an incredible job of trying to summarize, which was, hours of conversation into 2 minutes, just to give us a flavor, because obviously all of what you discussed will be taken and converted into themes by the MITRE and Code staff and delivered back to us so that we can then take it and share it with the 17 agencies that participated in developing the strategy. So that's our commitment to you. I promise we'll have many, many discussions, and we'll try to disentangle some of this feedback and think about where it can take us as we start to implement the national strategy. And that's really the goal, right, is to continue to do the work and make progress. There were a lot of really strong themes there: education, 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 collaboration, collaboration, diagnostics for sure. And so that's really reassuring to see that we're finding some common themes. Did anyone have any reactions that I can repeat here quickly that you were really struck by? Anything that was shocking, reassuring? Any of the above? Okay. You guys are all talked out, which is totally fine. Totally fine. So I will then sum up that we are extraordinarily grateful to all of you for sharing your time and talents with us, both here in the room and online. You are all here because you have been great collaborators with probably several or more of the federal agencies, and we rely upon you to provide your honest feedback to us, oftentimes critical, but always constructive. And we really rely upon you all to help us to stay in the right path towards having progress. Many of you may or may not know that I also teach public health leadership, and a big component of public health leadership is getting into the balcony using a systems approach to solve problems. And that means that you're looking at models and you're trying to understand those models and you're looking at it from different vantage points. And a really great quote in systems thinking is from Donella Meadows, who said, "Remember always that everything you know and everything everyone else knows is only a model." And so you all are helping us inform whether or not that model holds. And clearly we have a lot of work to do to inform the broader model for vector-borne diseases. So thank you all for joining us and for giving us a whole day of your time. I know that comes at the expense of family and other work responsibilities and friends. So Stick with us. We'll share with you a summary after we do a lot of work with Code and MITRE. And any additional feedback, please provide additional feedback on this event through this QR code. We would really like to use it to inform other events that Kristen and I and others continue to hold as we engage you all. But my very, very sincere thank you for a great day.
Produced by the U.S. Department of Health and Human Services.